on the dramatic, cinematic heart attack, the sudden chest-clutching event.
Right, the Hollywood version of a myocardial infarction.
Exactly.
Yeah.
But the actual battle is fought in the decades of silent endothelial dysfunction and, plaque accumulation inside our vascular system. So our mission for this deep dive is to decode Dr. Asifule's high-yield framework regarding the primary and secondary prevention of coronary heart disease.
Which is such a critical text.
It really is. Whether you are cramming for a medical board exam or just trying to catch up on your own cardiovascular health, or honestly, if you are just insanely curious about how the body works, this is for you. We are targeting the exact evidence-based strategies that stop the world's leading cause of morbidity and mortality in its tracks.
And what makes this specific framework incredibly powerful is its relentless focus on intensity. And categorization, really.
Categorization? How so?
Well, it forces a complete paradigm shift depending on whether a patient has already sustained structural damage or if they're entirely asymptomatic. You simply cannot treat a pristine artery the same way you treat an artery that is already ruptured.
Oh, wow. Okay, let's unpack this fundamental divide right away. Because it seems like the entire clinical approach hinges on it. We're talking about primary versus secondary prevention, right?
Exactly. And this isn't just some administrative or bureaucratic distinction. It dictates the aggression of every single pharmacological and lifestyle intervention we deploy.
So establishing the baseline here. The core philosophy is that patients with established ASCVD, that is atherosclerotic cardiovascular disease, have basically already proven that their vascular environment is highly volatile.
Yeah, they've crossed a biological Rubicon, so to speak.
Right. And because of that, they derive substantially greater absolute risk reduction from aggressive, high-intensity pharmacotherapy. The rules of engagement completely change the moment of plaque ruptures.
They have to. Before we dive into the weeds of the treatments, we should probably clearly define what crossing that threshold actually looks like clinically.
Good call. So having established ASCVD means there is documented physical manifestation of the disease, and the text outlines 4 specific conditions for this.
Right, the big 4.
Yeah. First, a prior myocardial infarction, so a heart attack. Second, chronic coronary syndrome or CAD. Third is an ischemic stroke or a TIA. And fourth is peripheral arterial disease, or PAD.
Yeah, and if you have any of those 4, the structural integrity of your vascular system has already failed. You are exclusively in the secondary prevention category.
Okay.
And at that point, the goal is strictly about preventing recurrent events and cardiovascular death.
Got it. So if you are free of those 4 conditions, you remain in primary prevention. And there, the goal is preserving that pristine state and preventing the very first event from ever happening.
Exactly. And the treatment matrix reflecting this divide is a really stark contrast. I mean, take statins, for example.
Right, the cholesterol drugs.
Yeah. In primary prevention, deploying a statin is a highly nuanced risk-based calculation. You are balancing lifetime risk against immediate intervention.
But in secondary prevention, it's totally different.
Oh, entirely. For secondary, it is almost a blanket rule. You use the maximum tolerated high-intensity statin therapy immediately, and that is regardless of where their baseline lipid panel actually sits.
Wow, so you don't even wait to see if their cholesterol is high. You just hit it hard.
Right, and we see that same radical divergence with aspirin, actually.
Oh, right. Because routine aspirin use is explicitly not recommended for the vast majority of primary prevention patients anymore.
Exactly. But the moment a patient transitions to secondary prevention, aspirin becomes foundational, assuming there are no severe contraindications, of course.
But, looking at the framework, it also establishes 2 non-negotiable constants across both populations.
Yes, the universal rules.
Right. Blood pressure targets remain fixed at less than 130/80 for absolutely everyone, and lifestyle modification is the absolute bedrock. For primary, it's your main defense, but for secondary, it's the foundation upon which all that heavy medical therapy is built.
Yeah, I mean, the underlying physiology demands that constant.
Yeah.
You cannot outmedicate a highly inflammatory, hypertensive baseline state. The drugs just won't work as well.
Okay, let me try an analogy here to sort of unpack this. I want to look at it through a home security lens.
Okay, let's hear it.
So primary prevention is making sure your doors are locked and your windows are shut. It's reasonable everyday maintenance, right?
Sure.
But secondary prevention is what you do after a break-in has already happened. The perimeter was breached. So now you aren't just locking doors anymore. You are installing a laser grid and guard dogs. Is it just a matter of acceptable risk?
I love that analogy. And Yes, it is entirely about acceptable risk versus absolute benefit.
Yeah.
If we push that analogy into the actual physiology, once the plaque has ruptured, meaning the break-in happened, the local environment inside the artery is flooded with tissue factor, inflammatory cytokines, and these highly reactive platelets.
So the house isn't just broken into, it's actively on fire.
Exactly. It's a biological emergency. So throwing the laser grid and guard dogs at the problem, which means high-intensity statins and dual antiplatelet therapy, that yields a massive absolute risk reduction.
Because the baseline risk of a second event is just so astronomically high compared to someone with perfectly intact arteries.
Right. The math changes completely.
That distinction completely reframes how I look at the clinical approach. So let's zoom in on those locked doors first and look at primary prevention pillar 1, which is lifestyle modification.
The bedrock of everything.
Yeah. Dr. Asafala's notes are incredibly unequivocal here. Before a doctor even touches a prescription pad, they have to address the daily biological inputs. And the very first input is smoking.
And the statistics there are pretty grim. Smoking roughly doubles the risk of a coronary event, but the biological bounce back is what's genuinely fascinating.
The bounce back.
Yeah. This isn't a situation where you quit smoking and then you have to wait a decade to see the vascular inflammation subside. The timeline of recovery is incredibly fast.
Yeah, the text mentions that heart rate and blood pressure actually drop within days of quitting.
Days. It's immediate.
And the risk of a heart attack falls within months. Then, overall risk approaches a non-smokers within just several years. I mean, it almost sounds too good to be true, considering the severity of the toxins in cigarettes.
Well, it really speaks to the resilience of the endothelial lining of your blood vessels. When you smoke, the carbon monoxide and systemic oxidative stress actively deplete nitric oxide.
And nitric oxide is the primary vasodilator, right?
Exactly. It keeps the vessels relaxed. So when you smoke, you are essentially keeping your arteries in this constant state of rigid spasm, while simultaneously making your platelets much stickier.
Yikes. So it's a perfect storm for a clot.
It is. But the moment you remove that constant oxidative assault, the enzyme that makes nitric oxide can actually do its job again. The vessels relax, the platelet reactivity normalizes. The physiological payoff is rapid, specifically because the insult was continuous.
It's like finally taking your foot off the gas pedal while you're heading toward a cliff.
That is exactly it.
So let's move from smoking to dietary interventions. The framework specifically highlights the pre-deemed and DASH diets. Now, we hear about the Mediterranean diet constantly in the media, but the actual mechanism behind it is what matters here.
Right, it's not just a fad.
No, it relies heavily on fruits, vegetables, legumes, nuts, fish, and olive oil.
And pre-deemed was such a landmark trial because it didn't just look at surrogate markers, like it didn't just measure weight loss. It actually proved a massive reduction in hard cardiovascular endpoints, like actual heart attacks and strokes.
Wait, really? Just from diet alone?
Just from the diet. The high polyphenol content in extra virgin olive oil and the omega-3 fatty acids in fish, they actively alter the lipid profile and reduce systemic inflammation at the cellular level.
Wow. And then there's the DISH diet, which the text says was engineered specifically for hypertension. So high blood pressure.
Right. DIET stands for Dietary Approaches to Stop Hypertension.
Got it. And that one is fruits, vegetables, low-fat dairy, whole grains, and restricted sodium. Now, we all know sodium restriction lowers blood pressure, but the expert notes point out that DISH incorporates high potassium intake as well.
And that potassium to sodium ratio is really the hidden mechanism of the DAS diet.
How does that work?
By increasing your potassium intake, you naturally promote vasodilation, and you actually enhance the excretion of sodium through the kidneys.
Oh, so the potassium kicks the sodium out.
Essentially, yes.
All right.
You are fundamentally altering the osmotic gradient across your vascular walls. You are reducing the sheer physical volume of fluid pushing against the endothelium. It acts almost like a dietary diuretic.
Which lowers the mechanical stress on the pipes. That makes so much sense. Okay, rounding out lifestyle, we have exercise and weight. The baseline recommendation is clear. 150 minutes per week of moderate aerobic activity or 75 minutes of vigorous activity, plus muscle strengthening twice a week. But the weight metrics are where I think the clinical approach gets highly pragmatic.
Yeah, they don't just look at BMI anymore.
Yeah, right. They want a BMI under 25, sure. But they specifically mention waist circumferences. Under 102 centimeters for men and under 88 centimeters for women. Why the focus on the waist?
Because it specifically targets visceral adiposity. Subcutaneous fat, which is the fat right under your skin, is relatively metabolically inert.
It's just stored energy.
Exactly. But visceral fat, the fat that is packed deep around your organs, that is essentially a highly active endocrine tumor.
An endocrine tumor. That sounds terrifying.
It acts like one. It constantly pumps out inflammatory adipokines and cytokines directly into the portal circulation. It actively drives insulin resistance and vascular inflammation throughout the entire body.
Here's where it gets really interesting to me, though. The framework emphasizes that a mere 5 to 10% total body weight loss significantly improves cardiovascular risk.
Just 5%.
Yeah, you don't have to become a fitness model to save your life. If someone weighs 250 pounds, losing just 12 to 25 pounds fundamentally changes their risk profile. That feels incredibly achievable for people.
And the reason that works is because that initial 5 to 10% of weight loss disproportionately comes from that highly inflammatory visceral fat.
Oh, so your body burns the bad stuff first.
Yes. You are draining the toxic metabolic swamp first. The systemic inflammation drops exponentially, even if the patient's BMI technically remains in the obese category on paper.
Okay, so we've reinforced the foundation, we lock the doors. But what happens when the genetic predisposition overrides those locked doors?
Then you need structural reinforcements.
Right. We shift sequentially to primary prevention pillar 2, lipid management and blood pressure. This is really the numbers game. Let's look at the ACC and AHA statin stratification.
It's a beautifully logical flowchart, really. You calculate the patient's 10-year ASCVD risk, and that number directly dictates the pharmacological aggression.
Okay, so at the top we have high risk. That means a 10-year risk of 20% or greater. Here we immediately deploy a high-intensity statin. So that's atorvastatin, 40 to 80 milligrams, or rosuvastatin, 20 to 40 milligrams.
Right, maximum defense.
Then we have intermediate risk, which is 7.5 to 19.9%. For that group, a moderate intensity statin is initiated. But the fascinating clinical dilemma is the borderline risk category.
Ah, yes. The 5 to 7.4% 10-year risk.
Exactly. It's this weird gray area.
It really is the gray zone of cardiology.
Yeah.
You don't want to commit a patient to decades of daily pharmacotherapy unnecessarily, but you also absolutely cannot afford to miss a silently progressing pathology that's going to kill them in 10 years.
So how do you decide? The framework provides these tiebreakers to navigate this. We look for risk enhancers, things like a strong family history of premature ASCVD or metabolic syndrome or chronic kidney disease.
Yeah, those tip the scales.
But it also introduces advanced lipid markers, specifically elevated LPA and ApoB. What are those exactly?
Well, ApoB, or apolipoprotein B, is arguably a much more accurate predictor of risk than your traditional LDL cholesterol.
Really? More than the standard bad cholesterol test?
Yeah, because every single atherogenic particle, so your LDL, VLDL, IDL, each one carries exactly one ApoB molecule on its surface.
Oh, I see.
So measuring ApoB gives you the exact particle count of atherogenic threats in the bloodstream, whereas traditional lipid panels just estimate the total cholesterol mass that is carried within them.
It's like counting the exact number of enemy ships rather than just estimating their total cargo.
That is a perfect way to look at it. And then you have LPA. This is a highly atherogenic, genetically determined particle. And it essentially mimics plasminogen.
Mimics plasminogen. What does that mean for the patient?
It means it not only drives cholesterol into the artery wall, but it actively promotes localized blood clotting at the same time. It's a double whammy.
Man, it really is a double-edged sword. So if those markers are elevated, it tips the scales towards starting statin therapy, even if they are borderline.
Exactly.
But if the decision is still murky, the text says we turn to coronary artery calcium scoring.
Yeah.
PAC scoring. I kind of think of it like looking for rust in the pipes before the water completely stops flowing. You use a CT scan to visualize actual calcified plaque.
Right. Because atherosclerotic plaque isn't just a blob of fat. As the vascular inflammation progresses, the smooth muscle cells in the artery wall actually undergo osteogenic differentiation.
Wait, osteo, like bone?
Yes, they literally transform into bone-forming cells and deposit calcium directly into the plaque to try and stabilize it. A SEEK score detects that exact calcium.
That is wild. The body tries to build bone inside the artery.
It's a desperate defense mechanism.
And the interpretation of the score is pretty definitive. A score of 0 means statin therapy can often be deferred. A score of 1 to 99 favors initiation. And a score of 100 or greater makes a statin strongly recommended. It really removes the guesswork.
It completely removes it. You move from abstract probabilistic risk equations to direct, undeniable anatomical evidence.
Okay, so that's the lipids. Now, the blood pressure targets are similarly uncompromising, under 130/80. The preferred agents listed are ACE inhibitors, ARBs, thiazide-type diuretics, and calcium channel blockers. But the expert notes say the selection is entirely dependent on comorbidities.
Yeah, you have to leverage the unique physiological effects of the drug beyond just lowering the pressure.
Right, like if a patient has diabetes or chronic kidney disease, an ACE inhibitor or an ARB is heavily prioritized.
And there's a fascinating mechanical reason for that. These specific drugs don't just dilate peripheral blood vessels in your arms and legs. They specifically dilate the efferent arteriole in the kidney.
The exit pipe of the kidney filter.
Exactly. And by dilating that exit pipe, it dramatically reduces the internal pressure on the glomerulus. So it protects the tiny nephrons from long-term damage while simultaneously lowering systemic blood pressure.
Two birds, one stone. And honestly, the mention of diabetes perfectly sets up what might be the most radical shift in this entire text.
Oh, absolutely.
Primary prevention pillar 3, the diabetes paradigm shift. The framework states explicitly, quote, modern diabetes care is cardiovascular care.
And that is a massive departure from history. For decades, endocrinology and cardiology existed in completely separate silos. We genuinely believe that if we just push the HbA1c down with insulin or sulfonylureas, we were solving the whole problem.
But we weren't.
No, we were just treating a surrogate blood marker while the macrovascular disease, the destruction of the arteries, continued unabated.
But now we deploy these heavy-hitter drugs. SGLT2 inhibitors and GLP-1 receptor agonists. These aren't just glucose-lowering drugs anymore. They act like structural cardiovascular armor.
That's a great way to put it.
The framework lists empagliflozin, dapagliflozin, and canagliflozin for the SGLT2 inhibitors.
And the mechanism here is just brilliant. SGLT2 inhibitors block the reabsorption of glucose and sodium in the proximal tubule of the kidney.
So you just pee out the sugar.
Exactly. You excrete the excess sugar in the urine. But the simultaneous natriuresis, meaning the loss of sodium, fundamentally alters the heart's hemodynamics.
It takes the strain off the heart.
Right. It reduces preload, it reduces afterload, and it actually forces the myocardium to shift its energy metabolism from free fatty acids to ketone bodies, which is a far more oxygen-efficient fuel for a failing heart. That's why we see massive reductions in heart failure hospitalizations with these drugs.
And then we have the GLP-1 agonists. Semaglutide and liraglutide. I mean, everyone knows them for the profound weight loss they cause, and they improve glycemic control. But the reduction in major adverse cardiovascular events, or MACE-E, is undeniable in the data.
Oh, it's undeniable. They seem to have a direct anti-inflammatory effect on the endothelium itself, completely independent of the weight loss.
So we are actively decoupling glucose control from cardiovascular risk. We're using metabolic modulators to achieve cardiorenal protection.
Exactly. It's a whole new world of medicine.
So what does this all mean for the old standbys? This brings us to what the text calls a highly tested concept, the massive aspirin reversal.
This one catches a lot of people off guard.
I bet. I mean, my grandparents took baby aspirin every single day because they thought it was essentially a cardiovascular vitamin. But the updated guidelines now state that routine aspirin is no longer recommended for primary prevention in most adults.
Right.
So why the sudden flip? What changed?
It is a pure risk-benefit calculus that shifted beneath our feet. You see, aspirin works by irreversibly inhibiting the COX-1 enzyme. This blocks the formation of thromboxane A2, essentially making your platelets much less sticky.
Which prevents clots.
Right. But that exact same COX-1 pathway produces the prostaglandins that protect your gastrointestinal mucosa from your own stomach acid.
Oh, so you are trading a potential reduction in clot formation for a guaranteed increase in gastrointestinal bleeding risk.
Exactly. Now, 30 years ago, when smoking rates were sky high, statins were totally underutilized, and blood pressure control across the population was generally poor, the baseline risk of having a heart attack was so incredibly high that preventing the clot was absolutely worth the stomach bleeding risk.
But today?
Today, because we aggressively deploy statins, we control blood pressure much better, and we use those SGLT2s we just talked about, we have stabilized the fibrous caps of plaques across the population. The absolute risk of a plaque rupture has plummeted.
Oh, I get it. The heart attack risk dropped, but the bleeding risk of aspirin remains exactly the same.
Exactly. The math simply no longer favors routine use for people who haven't had an event.
That makes perfect sense. And the USPSTF guidelines are strict on this. For ages 40 to 59, if their 10-year risk is over 10%, it's an individualized decision with their doctor.
Right, case by case.
But for adults 60 and older, do not initiate aspirin for primary prevention. There's a specific exam pearl here for you listening. A healthy 60-year-old without ASCVD should not start aspirin solely for prevention, period.
Yes. If you're doing this right now, talk to your physician, because the data says you are introducing a real bleeding risk for zero net benefit.
It really highlights how medical dogma has to constantly be reevaluated as background population health metrics change. So up to this point, we've spent this entire time talking about keeping the vascular endothelium intact, avoiding the first event.
The locked doors.
Right. But we must now pivot to secondary prevention. The plaque has ruptured, the stent has been placed, the myocardium has been damaged. We are dealing with established ASCVD.
And this requires a total psychological and pharmacological reset. The absolute risk of another event is exponentially higher now.
Right, the house is on fire.
Yeah. We are no longer making nuanced, borderline risk calculations. We are deploying the maximum tolerated defensive perimeter.
And the text provides the ABCDE framework to structure this defense. So let's tackle A and B. A stands for antiplatelet therapy plus ACE inhibitor, or ARB. Let's talk about the antiplatelets first. In a stunning reversal from what we just said about primary prevention, aspirin is back.
It is back, indefinitely, 75 to 100 milligrams daily. Because once an event has occurred, the patient is clinically proven that their plaque is vulnerable and highly thrombogenic. The cardiovascular benefit of stopping clots now massively outweighs the baseline GI bleeding risk.
But aspirin alone isn't enough initially, is it?
No, not at first.
Right, after acute coronary syndrome and actual heart attack, the framework mandates dual antiplatelet therapy, or DAPT. We combine aspirin with a P2Y12 inhibitor. Drugs like ticagrelor, prasugrel, or clopidogrel, and that's typically for about 12 months.
Think about the physiological state of an artery immediately post-MI, especially if a stent was deployed. A stent is a foreign metal object forced into a torn biological vessel.
It sounds violent when you put it like that.
Well, the body reacts violently. It is a massive magnet for platelet aggregation. The body wants to clot over it. So we use DAPT to effectively put a chemical Teflon coating over that highly reactive site. We have to completely suppress platelet function until native endothelial cells can physically grow over the metal stent struts and heal the injury. And that process takes roughly a year.
Okay, going back to my analogy, it's like hiring 2 elite security firms for a full year right after a break-in while you rebuild the shattered door, and then after 12 months, you drop back to just one guard the aspirin on permanent patrol.
That captures the escalation and de-escalation perfectly.
Awesome. And the other half of A is the ACE inhibitor, or ARB, which we discussed earlier, but the expert notes say they are particularly crucial if there is a reduced ejection fraction. It prevents the heart muscle from maladaptively remodeling and expanding after the injury.
Right, it stops the heart from stretching out and getting floppy.
Okay, moving to B, beta blockers and blood pressure control. There is a massive update here regarding beta blockers.
Oh, this completely rewrites decades of post-MI protocols.
Yeah, we used to think every single person who survived a heart attack got a beta blocker for life to protect the heart. But the guidelines now state that universal, long-term beta blocker therapy is no longer required.
Right. It is only specifically indicated if the left ventricular ejection fraction is 50% or less, or if clinical heart failure exists, or if there is ongoing angina.
Why a change?
The historical context is crucial here. In the 1980s and 90s, before we could rapidly open blocked arteries with stents, heart attacks resulted in massive swaths of dead myocardium. The remaining healthy muscle was placed under extreme mechanical stress.
It had to work twice as hard.
Exactly. Beta blockers, by blocking sympathetic epinephrine, slowed the heart rate down and reduced the force of contraction. They reduced myocardial oxygen demand and prevented fatal arrhythmias in heavily damaged hearts.
But today, because a patient can get from the ER door to a balloon opening their artery in under 90 minutes, we are salvaging the vast majority of the heart muscle.
Precisely. Many patients walk out of the hospital with a completely preserved ejection fraction. Their heart pump is fine.
So giving them a beta blocker is just giving them side effects.
Exactly. Subjecting those specific patients to the lethargy, the fatigue, and the blunted heart rate response of a lifetime beta blocker prescription offers no statistical mortality benefit whatsoever. We have to treat the actual physiological deficit, not the historical diagnosis.
That is fascinating. That brings us to the aggressive management of internal chemistry. The ABCDE framework, C and D. Let's look at C, which is cholesterol management. And in secondary prevention, the approach is hyperaggressive.
The goal isn't normal anymore. The goal is a radical alteration of the lipid environment.
Right, all patients with established ASCVD receive high-intensity statins immediately. We are looking for a 50% or greater reduction in LDL from their baseline.
At minimum.
Right. But if they remain at or above 70 milligrams per deciliter, we don't just accept it. The text outlines a rigorous escalation protocol. Step 1, add ezetimibe.
And the synergy there is great. While statins block the liver from synthesizing new cholesterol, ezetimibe blocks the NPC1L1 transporter in the intestinal brush border.
So it works in the gut.
Yes, it literally prevents the gut from absorbing dietary and biliary cholesterol. You attack the lipid burden from two completely different organ systems.
But what if the LDL is still stubbornly high after that? We step up again, right? To the PCSK9 inhibitors, evolocumab or alirocumab.
The pharmacology of PCSK9 inhibitors is honestly one of the greatest triumphs of modern lipidology. Normally, your liver clears LDL from the blood using these specific LDL receptors on the cell surface.
Like little lipid vacuums.
Exactly like vacuums. But there is this protein called PCSK9 that routinely binds to these receptors and just destroys them.
So your body destroys its own vacuums.
Yeah. But by injecting an antibody that inhibits PCSK9, the liver receptors recycle endlessly back to the cell surface. They aren't destroyed anymore. So the liver becomes a massive vacuum, clearing LDL from the blood at an astonishing rate.
And the text mentions that the European guidelines actually push LDL targets to under 55 milligrams per deciliter for these very high-risk patients. Why push the numbers so incredibly low?
What's fascinating here is that when LDL drops below 55, the physiological dynamics of the atherosclerotic plaque fundamentally shift. You aren't just stopping new plaque from forming. You are actively depleting the lipid core of existing plaques.
Wait, you are shrinking the plaque that's already there?
Yes. The fibrous cap thickens. The plaque becomes incredibly stable. You are literally starving the disease process to the point of regression.
Starving the disease process. I love that. That perfectly leads into diabetes control and diet. We already covered SGLT2s and GLP-1s, but in secondary prevention, there's a crucial nuance. The text highlights that the reduction in major adverse cardiovascular events occurs entirely independently of glucose lowering.
Right. This is so important. If a diabetic patient with ASCVD has an absolutely perfect, normal HbA1c controlled solely by old-school medications, the guidelines dictate they should still be heavily considered for an SGLT2 inhibitor, or GLP-1.
Even with a perfect blood sugar.
Yes. We deploy them not to fix the sugar, but to deploy the specific cardioprotective mechanisms we discussed earlier. The natriuresis, the improved myocardial energetics, the endothelial stabilization.
It's direct heart protection. Okay, which brings us to the final letter in the framework, E. And honestly, this is the most frustrating statistic in the entire text. E stands for exercise and cardiac rehabilitation.
It really is a systemic failure of modern cardiology.
Let me read this right from the notes. Comprehensive cardiac rehab is a Class 1 guideline recommendation, yet only 20 to 30% of eligible patients worldwide are enrolled.
It's abysmal.
And we aren't just talking about a treadmill in a basement. Comprehensive rehab includes supervised exercise physiology, nutritional counseling, aggressive risk factor management, and profound psychological support after a life-altering trauma.
And the physiological benefits are completely undeniable. The sheer mechanical stress of supervised aerobic exercise upregulates endothelial nitric oxide synthase, which dilates the vessels.
More nitric oxide.
Right, and it promotes angiogenesis, which is the actual growth of new collateral blood vessels in the heart. It essentially creates endogenous bypass grafts.
Your body builds its own bypass, and the meta-analysis data is crazy. It shows an approximate 20% reduction in all-cause mortality, dramatically reduced cardiovascular mortality, and way fewer rehospitalizations.
It's incredibly effective.
If a pharmaceutical company invented a single pill with that clinical profile, it would be a trillion-dollar blockbuster drug mandate. But because it requires time, sweat, and logistical coordination, it just gets ignored.
The board examination pearl here is absolute. Post-MI, post-PCI, post-CABG surgery, or in stable heart failure, referral to cardiac rehab is virtually always appropriate.
It is the ultimate integration of primary prevention lifestyle tactics forcefully applied to a secondary prevention patient. Okay, to bring this entire deep dive home, let's rapidly synthesize the critical high-yield updates from Dr. Safalla's framework for you listening.
All right, rapid fire. First, the aspirin reversal. It is individualized for primary prevention ages 20 to 59, but completely contraindicated for routine primary prevention in adults 60 and older.
Got it. Second, the secondary prevention LDL escalation step up. Maximize the statin, then add ezetimibe, then add a PCSK9 inhibitor, drive the LDL to the floor to start the plaque.
Third, GLP-1 and SGLT2 inhibitors are the new cardiovascular champions in diabetics. They are deployed regardless of whether the HbA1c is currently a target.
Fourth, the era of universal beta blockade post-MI is over. They are reserved now strictly for those with reduced ejection fractions, clinical heart failure, or ongoing ischemia. And fifth, the ultimate post-MI survival formula.
Right? Aspirin, a high-intensity statin, an ACE inhibitor or ARB, a highly targeted beta blocker if indicated, and mandatory cardiac rehabilitation.
That is how you prevent the bridge from collapsing twice. And honestly, it raises a profound philosophical question about the future of our field. Throughout this deep dive, we've highlighted that modern diabetes drugs are actually saving the heart entirely independent of blood sugar manipulation.
Yeah, they work beyond their original intent.
And we use blood pressure medications to protect the renal nephrons. If the pharmacological tools we invented to fix one specific metabolic parameter are actually stabilizing the vascular beds of the heart, the kidneys, and the brain simultaneously.
Are we witnessing the end of highly siloed medical specialties?
Exactly. If the underlying pathology of most chronic disease is simply one continuous, silent accumulation of endothelial dysfunction across all organs, perhaps the future of medicine isn't about treating a specific organ at all. Perhaps the future is treating the entire human vascular system as one massive, interconnected organism.
It's a compelling thought. It really makes you rethink everything.
It is exactly the kind of perspective shift that changes how we practice medicine. We started by looking at the silent rest on a bridge, and Dr. Asif Fullage's framework gave us the exact pharmacological and lifestyle tools to strip that rust, reinforce the biological rebar, and ensure the structure holds. Thank you for joining us on this deep dive into the primary and secondary prevention of CHD. Take these high-yield pearls to your boards or to your next clinical appointment, and we will see you next time.